happy Valentine Day to all of you who have joined me, and I bring my regards from Apex Hospital and IVF Center. We are primarily at Sirsa, but we have branches in Mansa, in Hanumangarh and Nohar as well. So, before we actually talk about infertility, we have to first understand how the reproductive system actually works in a female. So the anatomy, I'm not going to talk about that anatomy, which you never liked doing, but the basics. So I have a couple of slides. We all know that the menstrual cycle starts from here. So we have hormones which are secreted by hypothalamus, and then the hormones act on pituitary, which will secrete FSH and LH. Now, this FSH and LH is going to act on ovary to produce estrogen and progesterone sequentially. And then this estrogen and progesterone have effect on uterus as well, so that in the initial part, the uterus will form the endometrium, and after the ovulation has occurred, there is a release of progesterone from the ovary. Now this progesterone is going to help implantation, but suppose if the female is not planning a pregnancy, so then after 14 days of ovulation, we all see menses. So the slide which I'm sharing, I would like to talk just a little bit in detail with this, because that is how I'm going to explain how I manage my patients of primary amenorrhea. So we know it's not just the central nervous system. The environment again has got lots of role. When I'm talking about environment, I'm not just talking about the physical environment. I'm also talking about the inner environment, the stress and all, which can affect the central nervous system as well. So the central nervous system takes the command, and from hypothalamus, we get gonadotrophic releasing hormone. There are two types of gonadotrophic releasing hormone, one which will cause the secretion of follicular stimulating hormone, and the other which will cause the stimulation of LH. So now what happens is, once the menses have occurred, from the anterior pituitary, there is release of follicle stimulating hormone. This follicle stimulating hormone will act on the ovary to cause ovulation. We are going to go to another slide as well, so that I will explain it in the other slide also what I'm talking about. When this FSH comes, it is going to help the ovary form a follicle. Now this follicle is gradually going to release estrogen hormone, and this estrogen hormone will help the uterus in formation of the endometrium. Now, once there is enough estrogen, there's a feedback stimulation to the pituitary and the follicle is ready. So then there is a surge of LH. LH does not come like FSH. FSH comes in a gradual pulses every day. Very important to know that the FSH stimulation basically occurs early in the morning. This is one reason while doing any ovulation induction for IVF or even in IUI cycles, when we are using the hormones, the FSH or HMG, we always like to give them in the morning because we want them to synchronize with your body FSH stimulation. So this is one point I want to tell. Anytime you want to give injections, try and give in the morning. So now, once this endometrium is ready and the follicle is ready, the LH comes as a surge. I will be showing it in my other diagram as well. So don't worry, we are going to repeat what I have already talked. And this LH causes the follicle to burst and release the ova. approximately or almost exactly after 36 hours. Why I'm going to insist on this 36 hours? Because this is the basis for the way we do our IVF, because that is how we plan the pickup. So once the follicle is ruptured and there is LH surge, because of the LH surge, the follicle is ruptured. Now, whatever it is, the fertilization occurring or doesn't occur, this follicle, this residual follicle gets converted into corpus luteum. This corpus luteum will help to secrete progesterone hormone so that once the fertilization occurs, and it takes approximately 5 days for the embryo to convert into blast, after which it will get implanted. So by this time, the endometrium is ready for the implantation, and this corpus luteum is helpful. Now I want to talk one word about this corpus luteum. I have seen many a times in even a normal pregnant lady, she comes with a report of a cyst. Usually the ultrasonologist call it ovarian cyst. She's 6 weeks pregnant or 5 weeks pregnant or up to 8 weeks. And the doctors suggest that this cyst has to be removed. Normally the corpus luteum is not very large, but at times the corpus luteum can be really large and it might mimic a cyst. And we as obstetricians are not supposed to tell them to get it removed, because I have seen a very important patient of mine who traveled somewhere else and this cyst was removed, and the moment the corpus luteum was removed, there was low progesterone and she aborted within a week. So, whenever you see a cyst with a pregnancy and a live baby, just don't bother. Just make your patient relax and tell her that most likely it's going to be a corpus luteum. Let's follow it up. So now, suppose if the pregnancy doesn't occur, we all know that bleeding occurs after ovulation 14 days, exactly 14 days after that. Now I'm going to take you to the other diagram. Again, understanding menstrual cycle the way I like to explain to my patients. Menstrual cycle always start when your hormones go down. It's not just progesterone, it is estrogen as well. So once your hormone go down, there is bleeding. Like now what happens is, once this bleeding has occurred, there are various changes which are occurring at the level of the CNS, that is the pituitary, at the level of the ovary, and also at the level of uterus. So we are going to see all of them from this diagram. So, as I told you, once there is bleeding baby, what is the pituitary going to do? Obviously, under the effect of hypothalamus, but there is follicle FSH which starts being secreted from day 2 onwards. So this follicle stimulating hormone is going to affect the small antral follicle. Now I want you to pay your attention on the topmost part of my diagram, the ovarian cycle. From a little antral follicle, this follicle stimulating hormone will help in the development of follicle. I want you just to concentrate prior to ovulation. Now, as and by this follicle is developing, what is this follicle doing? It is going to secrete estrogen hormone. Now, this estrogen hormone, now you can see the ovarian hormones, 1, 2, 3, 4. The fourth part of my diagram, the estrogen hormone is gradually going up prior to ovulation. What is this estrogen hormone going to do? This estrogen hormone is going to help in the development of endometrium. Remember, Usually, as infertility specialist, we do a transvaginal sonography on day 2 of menstrual cycle. And what we usually like to see is a thin endometrium. What we like to see is that the endometrium has shed. So now we want the new endometrium to form. Naturally, as I'll go in my slides or I'll be talking about ovulation induction, I will show you these diagrams in my slides that how do we see the thin endometrium on ultrasonography and how do we see the endometrium as it is formed. So now we've seen that the follicle forming has also led to the formation of endometrium. And once we know that the follicle is ready, what happens is the anterior pituitary stimulates the LH. You can see in the diagram that the third part, the third box, that the LH is absolutely at ground level in the initial part of the cycle, but it comes as a surge, the blue one. The blue peak is the LH surge. It comes as a surge, and just a little bit after the LH surge, there is ovulation, the topmost part. Now, I'm not talking about the fertilization occurring or not occurring. What happens at the endometrium after ovulation? The endometrium starts having more blood vessels. It becomes hypervascular because it is preparing for the fetus to come. And now you see the fourth part. The purple is the progesterone. In the initial part of the cycle, there is absolutely no progesterone. We as infertility specialists always check it on the day of ovulation. If there is a progesterone rise, we will not do a transfer because we know that there won't be pregnancy. So the progesterone is absolutely grounded till ovulation. After ovulation, the progesterone rises. This progesterone is actually secreted by the corpus luteum. Now again, I want you to concentrate on the top part of my menstrual cycle diagram. The yellow one is the corpus luteum. The corpus luteum can look very differently in different patients because sometimes the ovulation occurs like a burst. So then the corpus luteum is almost a crumpled thing. But sometimes there would be just a little nick from where the ova is coming, and the residual follicle gets filled again with the fluid. So many times it will look like a follicle only. There are so many people who would say that the ovulation has not occurred because it looks like a follicle. I have seen lots of infertility specialists also reporting to people that you don't have ovulation even despite HCG. Then what do? They increase the dose of HCG. Again, they don't see. So what you have to see when you see a follicle-like thing only, once even if you've given HCG, but you still see that follicle-like thing only on ultrasound, just get a progesterone sample for this patient. If the progesterone is high, you know that the ovulation has occurred. So don't bother about it. It is a corpus luteum only. Right? So suppose if the pregnancy continues, the corpus luteum is going to flourish. It's going to be very happy. This corpus luteum just not releases the progesterone. This also will help in the maintenance of HCG. So suppose if the pregnancy doesn't occur, this corpus luteum is going to be crumpled like the corpus albicans you can see in the diagram. But if the pregnancy is going to happen, then this corpus luteum is going to flourish. It can even increase in size. So just don't worry. I've already talked about this. Now, what we see at the endometrium level, that the endometrium which was growing in the initial part, the follicular part, as a trilaminar looking, is going to convert into a secretory endometrium. just by experience, we can also tell that this endometrium is looking like the secretory. But today we are not going to worry about it. With this basic knowledge, now I want you to understand what is hypogonadotrophic hypogonadism and what is hypergonadotrophic hypogonadism. But no, I'm having. So now we've already seen this diagram. Now suppose a patient comes to you complaining of primary amenorrhea. So how do we go about? We're going to talk about it later, but I just want to explain this diagram to you once more so that you know what we call as hypergonadotrophic hypogonadism and what we call as hypogonadotrophic hypogonadism. So we've already talked that from hypothalamus, the gonadotrophic releasing hormone is released. Naturally, they are released in pulses, and this will act on anterior pituitary to release FSH and LH. We've already talked that how are they going to be released. From ovary, we get estrogen and progesterone, and the uterus, if it is properly going well and no pregnancy, it will lead to menses. Now, suppose somebody who's got amenorrhea, what is the first test we like to do? Once we've checked that there is no blockage in the passage, or there is no hymen, or there is no vaginal septum, what are we going to do is, one test is serum FSH levels. Serum FSH should be done on day 2 of menstrual cycle. And suppose if this patient is of primary amenorrhea and she's not bled with progesterone and she's not bled with estrogen and progesterone, then it is a different scenario. Then you can do a serum FSH. So what will happen is, if the serum FSH is too high, when I'm saying too high, I mean serum FSH more than 15. When the serum FSH is more than 15, we call it hypergonadotrophic hypogonadism. Just to understand that this patient's ovary is not working. So this patient is secreting gonadotrophic releasing hormone, and it is also releasing FSH. That is why you are seeing FSH in blood. But now when this FSH is going to the ovary, there is ovarian failure. That is why this FSH is not able to produce estrogen, and later on definitely the progesterone also from the LH. So a very high FSH will always be accompanied by very low estrogen and progesterone. So this patient, can she produce a baby? Yes, she can produce a baby, but we have to understand that her ovary is not working. She is a case of either primary or secondary ovarian failure. She can produce a baby by taking egg donation. So no form of ovulation induction is going to help her. That's it. So there's no point in giving her letrozole, clomiphene citrate or anything. If you see serum FSH very, very high, approximately, I mean, when I'm saying very high, I've seen cases of 60, 80, 90. Because what is happening? When the ovary is not producing estrogen and progesterone, there is a feedback stimulation that, estrogen and progesterone are not stimulated, because it is not the estrogen and progesterone which is required only to produce menses. Our overall body also requires estrogen and progesterone. So the feedback goes to the hypothalamus, and the hypothalamus is trying to work more, trying to produce more gonadotrophic releasing hormones, trying to produce more FSH. And that is why we see high FSH. Now, on the other hand, if you do serum FSH and you see a very low serum FSH, this means that either the hypothalamus or the pituitary is not working. It is not very important that there is a problem with hypothalamus or there is a problem with anterior pituitary. From our angle, from the angle of an infertility specialist, if there is no FSH, now naturally this FSH cannot go to a ovary, and estrogen and progesterone will again be very low in such a case. Don't expect that the estrogen would be high. So now we are going to talk that how are we going to treat such people. This is called hypogonadotrophic hypogonadism. Now, with this understanding, let us go forward. Now we are going to talk about primary amenorrhea. We all know amenorrhea is failure of menarche to occur when we are expecting it. I don't know if WHO, it's high time that WHO should change the 14 and 16 year, because we've all seen that menarche has gone to at least 2 years. What our grandmothers, the time they had their menarche, our menarche happened 2 years earlier, and definitely this generation has more understanding, they've got more of exposure, so the menarche is going much lower in age. But when we see secondary sexual characters, we can wait till the age of 16 years. But if there are no secondary sexual characters, it is high time that we start taking action even by the age of 14 years. Okay, so there are too many approaches. One approach is you can go from up to down. That is, you can see if the hypothalamus is working, then you can see if the pituitary is working, then you can see if the ovary is working, and you can see if the outflow tract is open or not, like that. But I usually believe in problem-based approach. So, yes, this is not more for us. We people are still staying in a very smaller part of India. But yes, for people who are staying in Gurgaon or bigger cities, it's not just the mother, it's the girl herself who would have done all the research before she presents to you. So what is the practical approach? Yes, we are going to take history, we are going to do physical examination, ultrasound examination, and investigation. But one message which I want to give to all the people who are connected with me is that I have seen whenever a patient of primary and amenorrhea would approach a gynecologist or an infertility specialist, what they do is, before actually understanding it by themselves, they're going to write an array of investigations which will include ultrasound, MRI, karyotyping, and blah, blah, blah. So, we are going to talk that how can we not increase the amount of investigation but still not lose on anything. So yes, very important, we have to rule out pregnancy. We have to rule out, because cases have been seen that there have not been periods, and before the first period, a pregnancy was taken. So you cannot say that the pregnancy is not there until and unless you have ruled out. Then second important thing, we have to rule out cryptomenorrhea. Before we start anything, just make the patient lie down, see if the tract is working or not. See if the hymen is not imperforate. I usually tell my people not to do PV with 2 fingers. If you can comfortably do with your little finger, apply lots of jelly and see if it is going. You can feel the cervix with this as well. Otherwise, so many times I like to introduce an IUI cannula to see if the vagina is there or not. So, once you have excluded pregnancy and cryptomenorrhea, then we are going to divide our patients in 3 groups, 3 basic groups. 1, there is amenorrhea. There are normal secondary sexual characters, but there is anatomic abnormality. So how to deal with them? We are going to talk about it. Second, there is amenorrhea, absent secondary sexual characters. Now the third group, amenorrhea with normal secondary sexual characters. So let's start with the anatomic abnormality. Naturally, if you are going to do any tests for this person, the hormones would be normal. Naturally, the hypothalamus pituitary is functioning well. There is FSH, there is LH coming right on time. The estrogen is preparing the endometrium. The progesterone is coming right on time. The uterus probably is also working, but it's not coming out. So this is my first patient. Now I'm going to present 4 or 5 of my cases so that you can understand that yes, this is how the patient comes. So this is a teenage girl with normal sexual development. Intermittent abdominal pain can be present, not present. There can be history of difficulty of maturation. There can be a palpable swelling. There cannot be. If she presents early to you, yes, they will not be there. And you can see the bulging membrane, hematocolpus. This is a very, very common case. All those who have been practicing for years have already seen it. If it is an imperforate hymen, it is very easy to incise, but sometimes if it is vaginal atresia, it is not recommended to just start doing it by yourself, because then you have to do it in the presence of a laparoscopic surgeon, in the presence of a urologist, because we never know what all is included. But suppose if it is a small vaginal septum, yes, obviously. Inside the membrane, some people just put a nick, some people give a cruciate incision, doesn't make a difference. Once a cut is made and once the fluids start coming out, it's managed well. Okay, now we are talking about another type of case. This is amenorrhea with secondary sexual characters, yes, but the uterus and the vagina are absent. Very commonly I've seen. I don't know if I've seen such cases because I'm practicing infertility or just like that, but till now I have seen at least more than 20 Rokitansky syndrome. So once we see that there is amenorrhea and we don't see, we see a blind vagina, we can put a finger and we just feel that only vagina can go up to just this part. So we know that there is blind vagina. You get an ultrasound done. The ultrasound will show a rudimentary uterus, right? So what is the first thing you are supposed to do at this stage when you don't see uterus and vagina? Here, the first investigation after ultrasound should be karyotyping, because there are 2 types of scenarios with uterovaginal absence. One is 46XX and the other is 46XY. Why is it important to differentiate both of them? As I'll go forward, I'll explain it to you. So we all know that 46XX is MRKH syndrome, the Rokitansky syndrome as I like to call it in short, and 46XY is internally a male, but phenotypically, genotypically, it's a male, but phenotypically, it's a female. Why? Because there is insensitivity. The receptors are not sensitive to the testosterone that is being produced by the body. This is actually a boy, but because of the receptor insensitivity, this will look like a female. And interestingly, the second one, in fact, the 46XY can have a baby by herself, because now, since this case has come to us and since the world know this person as a female, I would like to address this person as a female only. So interestingly, the second out of the two can produce a baby by herself, by obviously egg donation, but not the first one. Because the Rokitansky syndrome, patient will never have a uterus. But yes, with the advent of science, probably 10 years down the line, with the uterine transplants going up high, probably even the Rokitansky syndrome can also think of having her own baby. So now how will these two present? We are going to talk about it. Again, I want to remind you that we are dealing with the situation where the secondary sexual characters are present, but there is problem with the outflow tract. So now this is one patient where the secondary sexual characteristics are normal and the external genitalia is female. If you do a testosterone hormone with karyotyping to differentiate between the two, you can also do a testosterone hormone. So it would be in normal range because she is genetically a female. But her only problem is that her uterus and the vagina could not develop. But on ultrasonography, we see a normal ovary. So since the ovary is normal, since the hypothalamus and pituitary are normal, she is producing normal estrogen and progesterone. That is why her secondary sexual characters are absolutely normal. So her karyotype is 46XX. In 15 to 30% of these cases, there could be renal, skeletal, or middle ear anomalies. So we have to keep our eyes open and our mind open for such things. 15% of patients of primary amenorrhea are Rokitansky syndrome. So if 100 patients of Rokitansky syndrome will report to me in the coming year, 15 of them are Rokitansky syndrome. So I don't want you to miss on it. Okay. So now what to do? As per now, if she requires a baby, she can have it with her own genes. I have had a couple of patients who have given their own eggs but opted for surrogacy. In fact, a very interesting case which happened very recently is that the mother opted for being a surrogate. So we took the eggs from the girl and her mother acted as a surrogate. But what to do till she is going for marriage or she is preparing for her marriage? It's very important to create the vagina. Though I belong to a center which is doing very good laparoscopies and all plastic surgeries as well of all the females. So I want to tell you that we do all reconstitutive surgeries for females. That is, some people do come for hymenal reconstitution. Some people who are old, but they want their vaginoplasty. So we do all kind of such surgeries also. And we have done couple of vaginal reconstitution, but still I would recommend that don't get this patient done surgery. I have seen the results of both the things very well, from not my center, but from big, big institutions also, doing a surgery, putting a mold, putting a graft of amniotic membrane of her own thigh material. I've seen everything. But a surgery causes fibrosis. So once she is married and she'll go for intercourse, it is painful. But in the other scenario, the vagina is constituting of fibrofatty tissue. So a mold is the answer, and the answer. Don't go otherwise. Just use a mold. We have got couple of molds done with us, and we give it to patient. The patient can use it for 1 month or 2 months prior to her marriage. And I've seen big, big vaginas being constituted with this mold. I have got these molds done by a dental friend of mine, because it is the dental material which they do. It is even bigger than the size of a normal penis. He's also put a wire so that it's easy to handle. So if you get lots of patients, you can get molds made. Otherwise, you can also use, I think dildo toys are also very common these days. So you can ask the patient to get one of those dildo toys and can use it to create a beautiful vagina. Now coming to the other situation I told you, this is the androgen insensitivity syndrome. If I tell you, when I see a female who's got absolutely normal external genitalia, but absence of the outflow tract, or absence of uterus and vagina, or sometimes in such cases, uterus and vagina are also there. It is these situations where we can give them their own baby. I can diagnose just by looking at the breast. The breast is there, but it has got sparse glandular tissue and the areola is pale. The pubic hair are not the tanner stage 4 or 5. It is usually 1, 2, or 3, because I told you that the receptor defect of the testosterone hormone, or it is androgen insensitivity, and we all know that the hair growth is because of the male hormones. So you can make out that the female is looking normal. The external genitalia could also be normal. But because of this breast and the pubic hair, you can make out that this is most likely androgen insensitivity syndrome. Usually, you will see these females as a little bit more taller than the average, although there is no uniform rule. So I have seen such females with blind vagina and absent uterus also, but I have also seen them with a uterus also. So some of the patients will have a uterus, a vagina, but also testicles. So once you've diagnosed that it is 46XY, we have to get an ultrasound or an MRI test to see for where the testes are. We cannot miss it. It's not just that our purpose as an infertility specialist is to just give them a baby. If the testicles are placed inside the abdomen, high chances of them going into neoplasm. So we have to get them removed. Now again, we have done the testicle removal laparoscopically, open, every style for lots of patients. That is what I want to tell you, that even this androgen insensitivity is not so uncommon. It's just that we have to keep our eyes and brain open. So this patient, just to wind up, will have testicles inside either the inguinal canal or in the abdomen. The karyotyping is 46XY. The testosterone level is high. There is, that's it. That's what I just want you to take messages. So just to wind up in 1 minute, if there is blind or absent vagina, what? So if we see blind or absent vagina, if it is imperforate hymen, just do a septum or transvaginal. And if you see normal pubic hair, it's Mullerian agenesis. And if you see absent pubic hair and light areola, it is androgen insensitivity syndrome. So now we are going to talk about two situations where there are not good secondary sexual characters developed. I'm not going to talk about this once again, but if there are no secondary sexual characters developed, so there are two things. Either the ovary is not functioning, that is why estrogen and progesterone is not there, or there is a problem at the level of hypothalamus and anterior pituitary. So it is not secreting FSH, LH, that is why ovary is not producing. So how do we differentiate such a situation? We don't see secondary sexual characters. We do one test, that is serum FSH. If it is very low, it is hypogonadotrophic hypogonadism. Here, what we are going to do, I'm going to share in a couple of minutes. And the second situation is the serum FSH very high, where the ovaries are not functioning. No matter what you do, nothing will work. So what are you supposed to do here? You're just going to give her supplements. So this is case 4. Let's go case wise only. So this is another case where there is amenorrhea. It could be primary or secondary. Stature is short. Usually secondary sexual characters are not there, but sometimes you see them also. There is webbing of neck, increased carrying angle, chest is shield-like. Yes, I am talking about Turner's syndrome. There are renal defects also associated with it. So this is how a Turner baby is going to look like. She can have secondary sexual characteristics because sometimes they do have a little bit eggs. So during puberty, those eggs can help her having some secondary sexual characteristics, but sometimes she would report to you as primary amenorrhea. This is one patient of mine. She has already delivered twins. So, in cases of Turner's syndrome where you see amenorrhea and very high FSH, it is ovarian failure. For her to produce a baby, she requires IVF and egg donation. But for her to have her periods, if she is unmarried, but she just wants to have her periods, or for her to develop her secondary sexual characters, we have to give her cyclical estrogen and progesterone. I usually like to give estrogen, the Progynova kind of a thing, estradiol valerate for 24 days. You have to give high dose, at least BD for 24 days. And in the last 12 days, you can add progesterone so that she bleeds. What you're going to see, it is not just a high AMH is not just the Turner syndrome. It could be ovarian failure, which could be because of any cause, or no cause, unexplained. So if you see high AMH and she is unmarried and you have to give her the development of secondary sexual characters, you have to give estrogen and add progesterone in the end. After 6 cycles, you will see her developing her secondary sexual characteristics, and she will also have her periods in this time. She'll be very happy because she's got a normal uterus. But when she wants to conceive, she has to go for IVF with a donor egg. So, I've dealt with a situation where the FSH was high. Now I'm going to talk about the situation where FSH is going to be low. And when I say low, I usually mean FSH is less than 1. If you are seeing a female who's having a normal outflow tract, you've just checked that there's no problem, there is a small uterus, small ovaries on both the sides, the first test you're going to do here is serum FSH. And suppose if the serum FSH is low, less than 1, this means that there is some problem at the level of brain. Either the hypothalamus is not functioning or the pituitary is not functioning. We are not bothered if the problem is at the hypothalamus or pituitary. We just know that she needs supplementations. So this is how a hypogonadotrophic hypogonadism patient will present. She'll have a normal height, normal external and internal organs, though infantile. An ultrasound will show that the ovaries are normal, the uterus is normal, but the uterus would be rudimentary size. But FSH and LH are low. We have to rule out any intracranial pathology. 30 to 40% cases in Kalaman syndrome will be associated with anosmia. What are we going to do now? Hypogonadotrophic hypogonadism. We are going to replace hormonal replacement therapy when she doesn't want a baby, but when she wants a pregnancy. Good news is she does not have to go in for IVF. Every good infertility specialist or an obstetrician can take care of her. We have to give her HMG. HMG because what she doesn't have is hormones. If you give her hormones and don't give only FSH. Here she requires HMG. Usually the dose is up to 225 or 300. Okay, now the last case and last 1 to 2 minutes, amenorrhea with normal breast development with no outflow tract abnormality. Now these are again very common these days. She has everything normal, but still she's not menstruating. She could be a PCOS. There could be problem with TSH and prolactin. So this should be very important part of your investigations when you are seeing everything fine. Thyroid, prolactin, rule out PCOS, rule out ovarian failure. Sometimes anorexia nervosa, they either start, not eating at all, and then this is what I call the role of environment. Just to lose weight, they'll start dieting to very bad limit, and this will have the effect on CNS, and CNS is not going to produce FSH and LH. And exercise-induced disorders also at times. Okay, just winding up, thyroid prolactin high. Any time when the prolactin is very high, more than 100, you should get an MRI done. Serum FSH, when you see no outflow tract abnormality, but you want to rule out between hypogonadotrophic hypogonadism and hypergonadotrophic hypogonadism. What does an ultrasound do and what do we want to see in ultrasound? 1, presence of or absence of uterus, thickness of endometrium. Whenever we do an ultrasound, if the endometrium is good, it tells me that the estrogenized endometrium is at least there. I would give the withdrawal by giving her progesterone withdrawal and see that why she's not bleeding. So these are the cases where PCOS is very common. You will see hypertrophied endometrium, but because there is not balancing between estrogen and progesterone, that is why she's not menstruating. So the volume of ovaries, the antral follicle count, will also tell us if it is a case of POF, that is ovarian failure, or is it a case of multiple follicles and PCOD. So if uterus is present, first you can do a progesterone challenge test, but only do it when you see endometrium. On an endometrite, the estrogenized endometrium, when you give progesterone, she will have withdrawal bleeding. But suppose if you see no endometrium, then you will have to give her cyclical estrogen and progesterone. The karyotyping, I've already told you, when you see secondary sexual characteristics, but you want to rule out between the Rocky-Tenesky syndrome and the XY, the androgen insensitivity syndrome, and when you see very high FSH, you want to rule out if it is either Turner syndrome or is it the primary ovarian failure, just a simple primary ovarian failure. Thank you. Bye.
For more update, subscribe to our channel. Click here to keep watching.